Thank you for joining me for Dentrifice Update 2015 Benefits to Brush Up On. Before we get started, I would like to say thank you again for joining. It's great to see so many names here from around the world, actually. I have a few in my backyard, so those of you who are very close to me, hey, I'm reaching out to you and say thank you for joining, and good to see you here, and thank you so much for joining. Just a little bit about me. I'm a full-time practicing dentist in Columbia, Illinois, just outside St. Louis, Missouri, who started to practice from scratch. With that opportunity, I've been able to build a successful practice along with some terrific hygienists I work with and assistants that focuses on offering patients conservative, aesthetic care along with a team that is passionate on implementing a strong hygiene recare program. I'm a member of the ADA, AGD, ASDA, and AACO, and I'd like to take this opportunity to thank those organizations as well as those responsible for the program today, Viva Learning and Premier Dental. With that said, it's also a privilege to share with you what I get to do clinically every day, along with three of my hygienists, Tammy, who's a hygiene assistant, Karen, a hygienist, Brittany, and also Megan. Have you been to a toothpaste aisle lately in a local store? Here's a picture. It should be so easy. Organized colors, brands. Wow, I mean, it's all stacked nice and neat, you name it. But few shopping trips, let alone decisions, are more bewildering to your patients. What toothpaste to use? What whitens? What takes care of bad breath? What makes my tooth or teeth less sensitive? They're asking those questions. Then you start to add in all the flavors, the sizes, plus the ever-rising prices, and a simple errand for your patient turns into becoming a sensory overload. Patients rely on over-the-counter chemical agents and quick fixes often that find themselves on the shelves of the supermarket or pharmacies that promise to solve their dental issues. But really, these are only superficial remedies. An explosion of specialized pastes and gels brag about their powers to whiten teeth, reduce plaque, curb sensitivity, and fight gingivitis, sometimes all at the same time. There are currently around 400 kinds of toothpaste to choose from. No wonder patients call it the toothpaste trance when standing in that aisle. If they are leaving your office wondering what toothpaste or gel works best and where to get it, there's no better time right now to help them make that choice. You help them and need to guide them. Dental patients want to simplify, and they want to do it with education. You have the ability to put them in the right direction with your suggestions. Just the other day, I saw a patient who came in with heightened sensitivity to a cold in her maxillary left first molar region. After ruling out any radiographic pathology or caries, we decided and discovered she recently switched to a whitening toothpaste from the suggestion of her daughter. Clinically, she had some recession on tooth number 14, but it was only compounded by the use of a whitening dentifrice to create her sensitivity. Simple things like that, asking patients, what are you using, what are you doing, can make a big difference. Dentifrices are technically an oral hygiene medium, such as a paste or gel, to be used with toothpaste to maintain and improve oral health and aesthetics. Throughout centuries, most tooth powders, toothpaste, and mouth rinses have been formulated for some cosmetic reasons and others to improve cleaning, freshening breath, rather than the control of dental or periodontal disease. Many of these formulations are very abrasive and contain acidic substances. Some even incorporate antimicrobial ingredients such as arsenic and herbal materials. Increasingly on the market are the inclusion or mention of herbal extracts. With that said, there's little data to support their efficacy for gingivitis and none for caries prevention. Many agents even have the potential to cause damage to local tissues, if not even systemic toxicity. Here's a little timeline history. So looking back, we have over a 6,000-year history of oral hygiene products. And until recently, scientific evaluation confirmed their effectiveness. So it's been a long span of time. One of the biggest changes to toothpaste came in 1890 from W.D. Miller's chemoparasitic theory of tooth decay. There was the introduction of agents into toothpaste which might influence this process with the production of alkaline products. Not long after that, the beginning of the 20th century, various potassium and sodium salts were added to toothpaste as therapy for perio disease. The first ever double-blind, randomized crossover design clinical trial in dentistry was one a little over 50 years ago by Cook and Armitage. Crest hit the market in 1955 and then in 1960 became the first fluoridated toothpaste to gain the American Dental Association's seal of acceptance. The 1980s brought tartar control formulas, raising consumer expectations of what toothpaste can and could do. Ever since then, companies have brought out benefits and other ingredients, all in search of the next game-changing upgrade. More recently, ingredient additions have been ACP and Recaldent, followed by Novamin around 2004. We've already established that toothpaste formulations have evolved considerably. The key areas that Dentrifice's attempt to tackle are caries, sensitivity, and gingivitis. To date, the science shows that effective toothpastes are those that are formulated for maximum bioavailability of their active ingredients. Are the active ingredients stable long enough to make these claims? Can you believe all the marketing? Is there a toothpaste that takes on alone all the three that are mentioned above here? And what does the current literature show? We need to really delve into this. If all this seems overwhelming and you might say, hey, I'm a little bit confused, you really are in the right place. Because on this webinar, this program, I'm going to help provide clarity for you, give you some ideas and suggestions so how you can approach your patients as confident. You give them a direction. My hope is to provide you a better insight how you can customize Dentrifice choices for your patients by utilizing current science to better enhance clinical applications. I'll show you also a variety of clinical presentations that can directly benefit from toothpaste specifics. I want to make this actionable for you. In essence, I want to better explain current toothpaste components, their science, their effectiveness, and how you can recommend these products with confidence every day. But before we do that, I want to get down to just what are the basics. We've established that toothpaste is used to promote oral hygiene. It serves as an aid in removing dental plaque and food from the teeth, assisting in suppressing halitosis, and delivers active ingredients, most commonly fluoride, to help prevent tooth and gum disease, gingivitis. Essentially, it serves the purpose of improving the mechanical brushing and cleaning power of a toothbrush. Plaque is that film or biofilm bacteria that forms in the teeth and gums to prevent gum and tooth decay. The reality is most patients do not understand how to fully remove this plaque or biofilm. It's part of our responsibility to educate them. Let's take a closer look at the hard tissue, or enamel as we know it. Enamel is a highly mineralized substance and surface composed of rods. By composition, it's 96% inorganic, 4% organic, and then water. The hardest material in the body, basically. Yet, it is semi-permeable membrane with a constant flow of fluids outward from the pulp chamber, which helps to protect the tooth structure, but also provides sensation. Specific minerals such as calcium and phosphate play a vital role in tooth health. Together, they make a great team and help to vehicle fluoride into the enamel and work together to support remineralization. Saliva is another important influencer with all the protective factors it carries. We will get into that in a little bit, though. Another mineral, fluoride, helps to speed up the remineralization process to create a less soluble mineral surface. That applies especially to enamel and why we measure and need to measure enamel solubility. It's critical to remember that enamel gains minerals when mouth chemistry is neutral or slightly alkaline. The key takeaway here is we need to strengthen enamel. Therefore, whatever toothpaste you recommend, it must possess the right combination that promotes remineralization while buffering the saliva. I know that most of us know that we need to really, again, review a little bit about decay and what it is about exactly and what its definition is. Essentially, when acid-forming bacteria destruct the enamel surface, dental caries have formed. Caries is an infectious and episodic communicable disease caused by these acid-forming bacteria found in the plaque. The lactic acid produced by the carcinogenic bacteria dissolve the calcium and phosphate mineral in the tooth enamel in a process called demineralization. Baby teeth have thinner enamel than permanent teeth, so always be cognizant, making them much more susceptible to caries. So that's why it's really critical to make sure that we start kids off on the right foot with their oral health journey. This illustration shows the pH scale in relation to oral balance. The most important concept to remember is that caries is a dynamic process and not a static one. The dentition and oral bacteria are entwined in a cyclic reaction of demineralization and remineralization. It's a reversible process. Secondly, before cavity is formed in the tooth, the caries infection can actually be reversed. Caries progression or reversal is determined by the balance between protective and pathological factors in the mouth. Caries lesions form at pH of 4.5 to 5.5, as you can see here on the graph. Also noteworthy is when erosion lesions form, when the pH drops to 5.5. With each food or drink item that passes through the mouth, the oral pH becomes acidic and the tooth structure then demineralizes. Saliva must enter the equation of balance as well. Saliva buffering is able to reverse the low pH in plaque, and with a higher pH, calcium and phosphate can be driven back into the tooth enamel. Low intraoral pH is the main ingredient in the overall sequence, confirming the adage, if you don't address the pH problem, you cannot control the disease. Herein lies where you have influence. You need to choose a toothpaste that promotes balance and stimulates saliva. We know that saliva plays a significant protective function in maintaining good oral health, and because of its special properties, teeth would simply dissolve under the constant acidic attack. Saliva also provides a mechanical cleansing of the teeth and tissues. Human saliva naturally contains varying amounts of calcium and phosphate ions, but alone it may not be sufficient enough to aid in remineralization. Saliva has a critical role in the prevention of dental caries, as we've seen. One factor that lowers the risk of cavity formation is normal salivary flow. Anything less than 0.7 milliliters per minute increases the risk for cavity development. This is especially significant when assessing patients that present with xerostomia. Just today, I saw a patient who's undergoing chemotherapy. She has a very compromised salivary flow. She's susceptible to decay. I need to make sure, and so does my hygienist, make sure that we absolutely provide her a dentifrice that can stimulate her saliva. It's critical, or she's going to come back in several months and we're going to have some decay. Most of the patients we treat do not have ideal mouths. They present to us in conditions that are significantly less than that. They present with disease. That's why they're there. Tooth longevity should be our primary concern, and gingivitis can certainly interrupt that goal. Gingivitis is the inflammation of gums. A new study released from the CDC, Center for Disease Control and Prevention, confirms that nearly 1 out of 2 U.S. adults aged 30 or over, roughly 64.7 million Americans, has periodontitis. Remember, periodontitis starts as gingivitis. You should also know that supragingival plaque and chronic gingivitis have a high correlation. As you can see in this case here, this is a 19-year-old male patient. He's a classic example. We need to turn around where his mouth is going right now. We have great influence. Clinical research shows that plaque is a primary etiological factor in gingival inflammation. Left undisturbed, supragingival plaque reaches qualitative and quantitative levels of bacterial complexity incompatible with gingival health. Any method of plaque control is critical to rid this condition. That includes toothbrushing and, most importantly, your toothpaste choice. When the tooth's hard enamel wears down or gums recede, tiny microscopic tubes located in the layer of tooth below the enamel are exposed. This area may also include the root surface covered by cementum. Tooth sensitivity is caused by the stimulation of cells within these tubules, causing a sharp pain when the area is exposed to hot or cold temperatures through food and beverages, or even by the air. This exposure is known as recession and often is aggravated by aggressive toothbrushing as well as perhaps too abrasive of a toothpaste choice. Many of the over-the-counter whitening toothpaste also can contain components that are more harsh on these sensitive areas. Another cause of tooth sensitivity is cracks in the tooth surface, the enamel. Extreme temperature changes can cause teeth to expand and contract, and over time, microscopic cracks may develop, allowing hot or cold sensations to seep through to the nerves beneath the tooth enamel. At least 45 million Americans suffer from sensitivity at some point in their life. Dental hypersensitivity has been researched extensively, and it's been found to be underreported by the patient and is frequently misunderstood clinically. Two modalities that are used in the treatment of dental hypersensitivity are the alteration of fluid flow in the tubules and blocking the pulpal nerve response. Chemical modulators such as potassium nitrates appear to have limited ability to reduce the pain by depolarizing the nerve. However, toothpaste products that contain stannous fluoride along with calcium and phosphate ions have been proven to be very effective for tubular occlusion. They create a physical barrier that covers the open dental tubules to prevent external stimuli from causing pain or discomfort. Think of the exposed nerve endings, essentially the dental tubule surface is like a dry sponge in these areas. To work properly, that sponge needs moisture, and it requires nourishment. It needs to soak up things to work properly. So it needs to soak up the available nutrients and medicaments to soothe and seal its openings. As you can see here in this illustration, here's a dentifrice that in only 5 days is able to occlude the dental tubules. Obviously, this is a SEM here, and you can see in 5 days you've got a great occluding. That's a very, very significantly quick time, and I think patients, we live in such a quick, fast, urgent society today that when you can deliver something and patient says, yes, I'm feeling this and I'm feeling even better in that many, that works so much for your confidence level and how you can work clinically and push out products that really find great success. You've got to provide that for your patient. Really, really important. I want to tackle a little bit more next on how we go into what we're looking ingredient-wise in the toothpaste. You'll find that all these ingredients in toothpaste brands, although they are in a variety of combinations, it's important to understand what all of these ingredients do, their percentages within the composition, and what is their acceptable value for effectiveness. Abrasives are incorporated to remove debris and residual surface stains. Some of these examples are calcium carbonate, dehydrated silica gels, hydrated aluminum oxides, magnesium carbonate, phosphate salts, and silicates. I'll go more into detail on this in just a bit about abrasives. Humectants are added to prevent water loss in the toothpaste. Some of those examples are glycerol, propylene, glycol, and sorbitol. Flavoring agents are things known, like we know, as saccharin, xylitol, and other sweeteners that help to provide a taste that's more acceptable, but they do not promote tooth decay. Thickening agents are binders assist in stabilizing the toothpaste formula. They include mineral colloids, natural gums, seaweed colloids, or synthetic cellulose as well. And finally, detergents are added to create the foaming action. These may include sodium lauryl sulfate, SLS as we know it, sodium N-L-sarcosonate, and interestingly enough, no ADA accepted toothpaste contains sugar or any other ingredient that would promote tooth decay. I'll go more into detail on that in the last two categories with an asterisk in just a bit here, and you're going to see how we're going to lay this out. Taking a look at a common label, you can see here the toothpaste ingredient listing percentage by weight. When a percentage of abrasives near 50%, you need to be aware of the possibility of creating tooth hypersensitivity. And you can see here on this label exactly how everything's spelled out, the percentages, and by total. And again, things that near that 50%, you have to think to yourself, this is going to be more abrasive. It's weighted more so. It's got larger cleaning particles. My patient's probably going to develop, if they have any kind of aggressive brushing patterns or maybe a toothbrush that might have a harder bristle, this is really going to work against them, and they're going to end up driving more sensitivity. Keep in mind, again, this is percentages. You've got to look at the particle size, and we're going to go into those in a little bit here too. Here's a slide detailing basic abrasive values. Any value over 100 is considered abrasive. Obviously, the higher the value, the more potential for creating sensitivity, which is true especially for whitening products. The key is to find the particle size that is effective in disrupting the plaque for cleaning purposes, yet kind enough and gentle enough to the tooth and the gum interface. This kind of information is important because when patients come in with sensitivity, again, you begin the discussion by asking, hey, what toothpaste are you using? And you can quickly go to your guide and you can see here, oh, they're using, for example, say Sensodyne Extra Whitening. Well, you can understand that might create more of a sensitive type situation. This graph puts this abrasivity information into comparable perspective. You can see here where most brands range in the 50 to 180 RDA, or relative dentin abrasivity level. However, you do not see from the prior slides values that did exceed 200. And that's really amazing because our thinking needs to shift. The more abrasive quality does not equate to the more clean quality. Our office has been recommending a toothpaste the past several months that ranks at a 39 RDA, or relative dentin abrasivity, and a gel that ranks at 8 RDA with great success. Again, very low abrasive quality, but it does a great cleaning. I'll share some of those clinical results with you in a little bit, but as you look at this graph here, you see the upper limits of 200, and some of these toothpastes do rise above that. You've got to be careful what you're recommending, what your patients again are using, because they might actually be harming themselves with their with their toothpaste choice. Here's a patient that was actually harming herself, and you can see this. She had veneers for many years, and to keep her restorative work super clean and, as she said, really white, she wanted to use a whitening toothpaste. We all have patients that do this. I mean, this is daily. Take a look at not only the gingival recession from the toothpaste, but then as that gum level began to heighten, the staining became more pronounced because she was exposing her root surface. The root surface is more rough. Not only did that happen, but then she started getting sensitivity. She thought she was doing the right thing with the factor of the toothpaste choice she was using. But really, truly, it was too abrasive, and it helped to roughen up the restorative margins, and you can see here the staining. Since this patient came in, she's now gotten new veneers, and we also have her on a different toothpaste, obviously, because we want to keep her restorations in a long-term pattern, and now she knows how to keep them clean, keep her mouth and oral health clean and balanced, and do the right thing. Again, the toothpaste choice was harming her. Let's talk about fluoride. This is an ingredient that has been recommended for more than 50 years and found in many toothpastes, gels, etc. And it's most effective anti-cavity treatment today by its ability to strengthen tooth enamel and remineralize tooth decay. All ADA-accepted toothpastes contain fluoride. Both children and adults benefit from fluoride in their toothpaste, too. Fluoride can be found in saliva, and it will absorb under the tooth surface. We all know that, where demineralization can happen and begin to form, and it will aid in remineralizing the tooth. To make fluoride more effective at preventing cavities, calcium should also be present either as an ingredient in toothpaste or from the foods we eat. People tend to think that fluoride alone is responsible for preventing dental decay, but fluoride's efficacy is dependent on calcium availability. Fluoride prevents decay by chemically bonding to calcium, holding it into the tooth and attracting it from the mouth into the tooth to replace what was lost. This is critical to remember this. The entire tooth can remineralize itself, taking in calcium from the diet or from toothpaste as long as no cavity has already formed. Here's a few listings here of types of fluoride. You can see here we got stannous fluoride, sodium fluoride, acidulated phosphate fluoride, as well as sodium monofluorophosphate. And again, there are different tag names, SNF, sodium fluoride. You can see here APF, MFP. And you're going to see these listed here in a little bit because we're going to review a couple of the labels and how they're written out and what they do. But a couple of the common brands that are on the market today that we use in dental offices, as well as, again, many of the over-the-counter brands. What you see is many MFPs are in the over-the-counter. So how fluoride is delivered, what type of fluoride is used in different medications. Obviously, Periomet has stannous fluoride. You can see some of the Control X toothpaste has sodium fluoride in it. Enamel Pro, another good product, has APF. So they all have different types of fluoride, but then again, they need to bundle or partner with something to make them extremely effective and help them work appropriately and make sure that they have the right combination for that efficacy. And again, go back to the point where fluoride is totally dependent on calcium availability. Without calcium, none of these fluorides are going to have their effectiveness. So that's a really key ingredient. Oh, I've got a couple of nice little questions here that are coming in, and I'd like to answer some of these right here right off the bat. I have one question here. What about whitening toothpaste causes sensitivity? Yes, they do cause a sensitivity because, as you see here, they have a larger cleaning particle. They're more abrasive. Their RDA, their relative dent and abrasivity, is higher. And so you need to find a whitening toothpaste that is kind to the tissues as well as not only to the gums, but also to the enamel, and as you can see, the restorative work. One of the things you might want to pay attention to when you're looking for whitening toothpaste, which, by the way, there's really no great studies out there that show these toothpaste actually do whiten teeth, which is interesting too, but I know there's some out in the market that help really motivate patients. Maybe it's because they're brushing more. They might get that benefit, but really critical to see, again, what the particle size is and go back to that percentage of what's available within that whitening toothpaste here. All right, let's go forward here a little bit, and we'll talk a little bit how you're delivering fluoride. And actually, let me back up 1 second here. I'm going to talk a little bit more, a couple of things here I want to point out. Stannous fluoride here has been around for decades, okay? And it does inhibit bacterial adhesion and growth. We do know that. We know from Tinanoff that the inclusion of the tin ions, as you can see here, that in stannous fluoride, it will decrease gingivitis. This is a critical element too. And I got this asterisk because you need to remember later on as we go on that stannous fluoride is a big player in working along again with calcium to be taken into the enamel. So it's a really great product to know and have it in your ingredient listing. It has an antibacterial effect, especially on strep, and that's the key anti-caries influence there. So again, it's been clinically demonstrated to reduce plaque more than sodium fluoride. Just because a dentifrice has more fluoride, again, does not equate it to a stronger enamel. We need to be mindful of this. More fluoride does not mean a better or stronger enamel. I can say it again, I can say it 20 times. It's really true. In fact, the opposite can happen. So our thinking is changing. Less can be better if it's correctly partnered. Traditional sodium fluoride with 5,000 parts per million toothpaste protects against caries, but against, again, making the claims that it prevents sensitivity or gingivitis are not there in that claim making. That's marketing that people tell you this. It's not the case. So again, traditional sodium fluoride toothpaste that you get that are pushed out through your office prescription-wise, they can only make the claim that they are going after caries, dental decay. The takeaway here is, what is the right type of fluoride? What makes it most effective? And how much fluoride do you really need to recommend? Delivering fluoride here. We got different methods here: foam, gel, rinse, varnish. The upper two pictures are home care methods, obviously, and the lower two are office applications. The reason I'm showing this is because we need to really consider how patients, first of all, how much they're using, and then you need to also consider what's their compliance. Really critical to know that they're doing the right amount, they're doing the right dose, what's best suited for them, and they're following the instructions. I mean, you might have someone doing a fluoride rinse, but they're interrupting it 5 minutes later with something else, so they're not getting the benefit. Here's the takeaway. You got kids who might be dispensing toothpaste on their brush, but yet no one's following after them, and they need that supervision. So they might be actually ingesting more than what they need. And again, the takeaway is understand we need to give them the right tools so that they have the chance for correct use and compliance. There's no doubt that the pre-eruptive and post-eruptive influences of fluoride on human enamel are very important. That's why patients come in your practice, and you see the lower two pictures where we're doing fluoride varnishes, we're doing fluoride in the trays, APF in the trays. So we're doing different methods and approaches to deliver the best of what we know. But the bottom line is, again, we're back to the proper use, the efficacy, and what is the compliance. Here's some fluoride comparisons, what's out there right now. Traditional toothpaste that you can get over the counter right now are anywhere between 1,000 parts per million and 1,500 parts per million. Prescription toothpaste is going to be 5,000 parts per million, so considerably different, about 5 times different the level of fluoride. So you need to keep that equation in perspective there when we're talking about what we're going forward here with. That breakdown is important here. And also, you might have patients who come in who are very exacting, and they want to know, exactly how much fluoride are you talking about here? If you're going to prescribe a toothpaste for me, how much is in there? Well, you need to know those numbers, and you need to know the percentages. So really critical to do that. Also, rinses that you're going to look at traditionally over the counter are going to have about 230 parts per million, and usually that's a sodium fluoride of 0.05%. And then the prescription rinses that you're going to push out through your office, they're going to be about 900 parts per million. By doing the math, you can see here that I've got the 1,000 parts per million and how about 1.0 milligrams of fluoride per milliliter. So you can kind of do the math, work that from there, but essentially, you're going to have to sit there and figure out exactly about how much toothpaste. So if you take it, like say, for example, a 6.4 ounce of toothpaste, of MFP toothpaste over the counter, 1,000 parts per million fluoride, you're going to have right around about 192 milligrams of fluoride. We're finding more and more patients are asking how much fluoride is in this and what does this contain? They're questioning ingredients. And I know last fall there was a lot of news about some plastic binders being placed in a large companies over-the-counter push-out toothpaste brand, and people are concerned. Things are in the news. They want to be educated, and they want to know what you're doing for them. So, again, do your math, figure out, be exacting with them and precise, and that's going to help them be confident in you because you know your stuff, and that's really important. So this conversation that is kind of somewhat come mainstream with topical fluoride exposure is out there. We've got definitely a decline in caries. There's a rise in dental fluorosis, though. And what this technically is a chronic condition caused by excessive intake of fluorine compounds marked by modeling of the teeth. As dentists and hygienists, our goal is to promote the benefit of fluoride, but avoid the risk of what we term enamel dysmineralization associated with excess fluoride. These concerns are not just limited to dentists, but you've got pediatricians around you that are very well aware of what the potential of too much fluoride is. And as a hygienist and dentist, the dental health care professional, it behooves you to understand where are the concerns, how do you address these, and again, individualize for your patients what they need to do. So compliance becomes a very big issue here. And you're thinking about, again, go back to kids. How often are they brushing? Okay, how about adults? You try to promote them 2 times a day, 2 minutes a day, but still, you lack in that. Kids even have a harder time. We're all disrupted today with interruptions. Our lives are busy. Things distract us. So it's very important to make sure that you have compliance and you're like the cheerleader for them and helping them understand what's necessary and why it's necessary. Make sure they know the proper dose. Again, we can go on and on about that, but again, incredibly important to know how much is too much. And it's good to show them pictorially within your office. You pull out a toothbrush and put a little bit of the paste on. Show them exactly how much they need to do, especially for kids and for parents. Marry that conversation with showing them both together and making sure that the parent does track the child and how much they are delivering. We'll talk a little bit about that in a bit. Also, the frequency we talked about goes in with the compliance, as well as if there's too much, they're definitely going to ingest it. So that's not a healthy thing by any means. The conversation that becomes more onto this point about how much is too much. You can see here from these different delivery systems here, it varies according to the dispensing porthole. And this is critical. Be well aware that there are several studies out there that show caregivers often dispense twice as much toothpaste as they should. In a little bit, I'm going to show you exactly suggested amounts for children in a few slides. And more onto this point here, it's a label I took from a Dentrifice tube within my own drawer. Looking at these drug facts, and I know this is not the most of clear pictures here, but the active ingredient here is sodium monofluoral phosphate, so it's MFP. And what you have here is some warnings. And technically it says here that you need to keep out of reach of children under 6 years of age. If you accidentally swallow this, you're supposed to call Poison Control Center. So you need to be cognizant of these toothpaste labels have warnings on them. You need to seek care. Supervision is critical. And just because you're pushing out something doesn't mean it's totally safe for everybody. It's not. Really critical to read on further through that label that kids under 2 need to consult, a dentist. So you've got some important issues here to discuss and make sure that choices are right, that marry right with your patient for what they need. So it makes me concerned when, you see these kind of things and people can be very casual. They pick up something, oh, this is a whitening toothpaste. Oh, this is great. Well, maybe not, because what if my child ingests this? We've got a problem. We're going to be calling the Poison Control Center. I'm not advocating here technically that this is always happening, but you got to be aware of this stuff. Here's an interesting graph here, more onto this point about how, where's fluoride at, how much fluoride, can we lessen the fluoride but still have good, strong enamel? And this is a great illustration here showing you some leading brands recommended by dental offices today. You got Enamelon, ClinPro, and MI Paste. And actually it's MI Paste Plus. What you have here is the ability to lessen the amount of fluoride within a dentifrice. However, the enamel uptake, the fluoride that goes into the enamel, is really amazingly greater. And the uptake's about 2.5 times greater. And that's pretty amazing. This comparison shows products here that you have 1,000 parts per million versus another one that has 5 times as much fluoride. So think about the differences here. So this shift in the chemistry is for definitely less fluoride. The results are astounding here. I'm going to reiterate that because, to have an uptake comparison is pretty dramatic here. The explanation is there's probably a greater bioavailability of calcium and phosphate ions to enhance the fluoride uptake utilizing the remineralization technology of ACP. So you can go back and mind here and remember which products are available that have different ingredients here with the MI Paste. It has recaldent in it. You got the ACP chemistries going on in there as well as some other, and we'll go into those in just a little bit here too, and I'm going to go more into detail on these, but again, really critical to understand exactly what components are being able to vehicle with each. So calcium is absolutely able to enhance that fluoride uptake, and we talked about that earlier, but I'm going to keep talking about that because it's definitely critical. So you're having the ability basically to promote a dentifrice that's more effective with less fluoride, and it's safer. So I like that. I think that's a great partnership, and that's a great place to be here. We need to really rethink about how we deliver fluoride and what's most effective. Let's look at some of what other ingredients are in here and what they like to target. These are interesting too, because some agents appear on these labels that control the biofilm, but a lot of these are very broad spectrum. They're very non-specific microbiocide components, so they really kind of scatter approach what they're going to target here. Some toothpastes contain ingredients such as potassium nitrate or strontium chloride to help reduce tooth sensitivity by blocking the transmission of sensation of the surface of the tooth and nerve, like we just talked about here. Stannous fluoride, like we mentioned earlier, and triclosan help reduce gingivitis. Specifically, the tin ions in the stannous fluoride decrease not only gingivitis, like we said, but they also possess an antibacterial quality, especially effective on strep mutans, so against definitely caries. Pyrophosphates, triclosan, and zinc citrate also help reduce a buildup of hardened plaque, or tartar as we know it. Then you have your modified silica abrasives, or enzymes that help to whiten the teeth by physically removing surface stains, and other ingredients such as triclosan have also been proven to show they help reduce bad breath. I do have an asterisk by triclosan because there is some known causes that it will create dermatitis. This clinically appears as a red or sloughing gum, so you need to be aware of that. It's also a good reminder to ask patients at the start of their hygiene appointments, what toothpaste are you using? And again, get a good barometer where they're at, what they're trying to target for themselves, and what their understanding is of the market out there as well. Of course, other ingredients that are out there incorporate sodium lauryl sulfate, dyes, gluten, and essential oils. So it's always good to know what you're suggesting and what's working. Completing our previous timeline is CCP and ACP, or as we know these things, casein phosphopeptide and amorphous calcium phosphate. The recaldent technology was developed and introduced in February 2002, and more recently in MI Paste, introduced in the mid-2004 area in the United States. Recaldent, or as we know it as CPP or ACP, is a complex of casein phosphopeptides, a protein found in milk, and amorphous calcium phosphate. Be careful with this product if you do have patients with a casein allergy. This complex is said to adhere to plaque on the tooth surface and release calcium and phosphorus during a normal acid challenge in the mouth, which can then be used for tooth remineralization. Most of the scientific research conducted on recaldent relates to its anti-caries benefit. Recalcitrant has been shown in several laboratory studies and in one clinical study to be effective in remineralizing caries lesions and to interfere with adhesion of some bacteria to the tooth surface. Right now, there are no clinical studies available that address the ability of recalcitrant to reduce tooth hypersensitivity. The ACP technology requires a two-phase delivery system to keep the calcium and phosphorus components from reacting with each other before they're used. And current sources of calcium and phosphorus are two salts, calcium sulfate and dipotassium phosphate, that when they're mixed together rapidly form this amorphous calcium phosphate, or ACP, that goes onto the tooth surface. This precipitated ACP can then readily dissolve into the saliva, and then it's available for tooth remineralization and uptake. Also, other brands that are out there that incorporate recalcitrant or ACP try to bolster that they have claims such as liquid calcium. It's kind of interesting. So you know what? These do not require approval from the FDA to make these claims as well. So don't get confused. Remember that the Phyte's cavity claim comes only by being associated with a mention of fluoride in the toothpaste. The most recent introduction is Novomin. Novomin was initially developed as a bone regeneration material. It is made of bioactive glass containing sodium, calcium, phosphorus, and silica, which are technically all elements naturally found in the body. When Novomin particles come in contact with saliva or water, they rapidly release sodium, calcium, and phosphorus ions in the saliva, and then they're available for the mineralization process like we've talked about with other products. Unlike the other calcium phosphate technologies, the ions that Novomin releases form hydroxycarbonate apatite directly and without the immediate amorphous calcium phosphate detailed above, like we talked earlier. And Novomin has been shown in clinical studies to be a very significant tubular occluder. So it is a very great desensitizer. So keep that in mind for that type of specific application. So here we are talking about how do we measure effectiveness, and we're talking about ingredients and lots of chemistry, and I'm throwing a lot of different ideas about what partners and works well together, but I want to make more sense of how this materials choice is measured and how it does really affect the oral foundation, and how do we really find out what is truly effective and what isn't. There's several ways to assess this and to compare the benefits. We've already talked about mineral uptake, abrasivity, and fluoride safety. Now we're going to see some comparisons here that help you make really the right choice between balance and preservation, as well as much as prevention here. So the first one here, we've mentioned here, we talked about RDA beforehand and the abrasivity guide I showed you earlier, but on to this point here, enamel solubility is really, really important. A critical test is how is the enamel, how strong it is, what is its chance for decay or demineralization, or vice versa, remineralization. And you can see this test here that's laid out. Basically, they're using glucose. When you add it to the saliva, you get a container of powdered enamel. You're going to have different organic acids that are formed. And these acids then penetrate the calcium, essentially. Then calcium becomes free, and then there's a measurable amount there that can be a direct measure of how caries can form. They're testing how the enamel is losing its chance to be strong, and so therefore the lesser amount of calcium, the better uptake, the stronger the enamel you're going to have. So again, enamel solubility is a critical measure of what kind of toothpaste work and why they work. If you look at this graph here that I've got out, again, here's a recent testing measuring enamel solubility of 3 brands. You got Enamelon, ClinPro, and MI Paste. You can begin your comparison looking into the levels of fluoride. Again, one would assume that more is better. It's not in this case. What becomes important is how the fluoride is partnered to achieve a better uptake into the enamel so that the enamel solubility is reduced. As you can see, even though the first brand has less fluoride, which in comparison is a terrific amount of difference here, the other ingredients are mainstay in the calcium and the minerals to create a more resilient surface almost by 3 times. And that is statistically very significant. So I'm confident if I'm going to recommend, obviously the number one product here that I can see here on the left, Enamelon, it's going to work very well for my patients. It's going to be a solid promoter of strength in enamel. I'm going to move into a little bit here on some clinical presentations that we see daily within our practice. And before we even get into those, though, the first thing we do when we've arrived at within our practice is how we do a clinical evaluation for every hygiene patient. And we've kind of devised this little system. It's very quick and easy, but for us, it helps to get a handle on their oral condition and quickly find out, what their enamel presentation is, the feel of the enamel, soft, is it dense? We look at saliva level. We look at the plaque level, if they come in with plaque. We look at any kind of slight bleeding or puffiness in the gums. Obviously, radiographs are going to measure, as well as other early caries diagnosis devices, which we do use in our practice as well. So we're ranking each of these, and we also do, along with the 6-point probing, perio probing, we're going to arrive at some kind of treatment need, and then we're going to recommend some kind of Dentrifice from this gathering of information, which I think is critical to do for every patient. Here's some of the patients that we treat daily in our office. You can see here this patient is moderate gingivitis. If the plaque's not removed on that gingival interface, gingivitis is going to continue, because it's going to go into periodontitis, and then it get worsened, and even the chance of getting caries is going to be great. You can see here there's a lot of supragingival plaque on this patient, and they do have now class 5 caries formulating pretty actively. You can see there on the premolars as well as the molar, and this is significant. This patient needs direction, they need education, they need to get a regimen here. And I'm confident that if we can recommend a toothpaste that can help really attack the gingivitis, work with their brushing technique, improve their routine, create a systematic approach for this, they're going to have a better win-win. One of the issues I think that we all struggle with too is compliance of patients. You might give them great tools, but they leave there and they don't know how to use the tools. So again, education is first and foremost in all of this, and give them something that can minimize their approach, but yet can give them a maximum benefit and maximum success. And it's nice, I can give one toothpaste to a patient, recommend it, and they can use it, or a gel, and it's going to cover all those little all of those gingivitis, caries, and sensitivity issues. So again, that's critical, really, really important. Here's a patient here that recently we saw that has mild periodontitis. And the patient had, a good accumulation of tartar, calculus as we know it, and you can realize that when that patient leaves, they're going to have very sensitive teeth. Their root exposure is going to be there. They're going to have an uncovering that's been protected with the tartar, obviously, the calculus, and once that's exposed, they often do not want to come back, and we see this daily. So how can I make this a better event for them, and how can I be reassured that when they come back in 3 months, they're going to be healthier and happier? And one of the things, and here's a patient we started last November. She came back 3 months later. We put her on an Amylon. She was using an Amylon toothpaste and placing that with her regular toothpaste, and then she'd follow that with the gel twice a day. And I'm telling you, she had her mouth, she looked like a superstar patient, completely turned around, very compliant, and very excited that she was on the right road. And some of her comments, my teeth feel slick, they're not sensitive. You follow up with patients after they've had a quadrant scaling, replaning, and you want to handhold them if they've not had this happen to them before. And again, provide right comments to them, right direction, right products, and I think it's definitely a win-win for them. So really important and really critical here. I'm going to talk a little bit about recession. Here's another issue that's very, very important. Particle size matters with this toothpaste now more than ever. And we've seen here, no toothpaste are created equal. You make sure when patients have recession like this, they need to make sure they're changing. They have their appropriate toothpaste. They need to change into a very kind, gentle toothpaste or gel. They need to really avoid acidic foods. Make sure they have the proper toothbrush and that they're not brushing aggressively. If it's not gone in 3 or 4 days, they need to seek your advice, and you need to get some kind of game plan. What's happening here? Adult patients that have root surfaces that are exposed between the different aggressive habits, or perhaps again the toothpaste choice, you can really modify their habits and really develop a good win-win for them quickly. Again, just a change of the dentifrice and a change of the toothbrush habits, and they're going to be a very greatly improved patient here. Now, the condition that we commonly see is root caries. This is an imbalance in the oral system. It's causing a dissolution of tooth structure. Root caries occur at a higher pH, and like we talked about earlier, we have erosion that's at 4.5 to 5.5, and then you have root caries occurring at 6.2 to 6.4. You've got a softer surface to work with, and that root surface has only about half as much mineral as what the enamel does, and so it lends itself to being less defensive, essentially. This patient will immediately get reviewed here. We're going to critique this patient, assess this patient. We're going to look at what kind of current medications they're on. We're going to do a salivary flow review. We're going to look at their brushing and flossing. Obviously recommend a saliva substitute. Dietary issues are going to be addressed. And then honestly, we're going to put this patient on enamel on, and we're going to make sure that they have the benefit of having an ingredient called ultramulsion, which aids in soothing the gums. But it's also going to be a very nice sized cleaning particle that cleans it, delivers the fluoride along with the calcium into the targeted areas, but it's going to do it in a way that helps reduce the gingivitis and really go after prevention of caries. And that's the double whammy that you've really got to work with on patients like this. Root caries are a struggle. We have more and more patients that have dry mouth, and again, you see this as well, xerostomia. When their salivary flow is low, it welcomes a lot of things. We really rely on saliva to do so much. And patients are really, it's a challenge here. They're very susceptible to root caries with xerostomia. Again, review their physiology, look at their medications. We're seeing more and more medically induced xerostomias now than ever, and it is a very significant problem. One of the keys in treating a patient like this is you need to realize that you've got to stimulate their saliva flow. So if you can do that, and recommend, again, a toothpaste that works with that. Also, a saliva substitute is a really great advantage here. Whatever toothpaste you're going to recommend, they've got to make sure that it's got to be, has a very low, it's very low abrasively, because you don't want to, again, stir up anything that could cause harm. You want to keep everything as gentle and as kind. You also make sure that you don't recommend any products that have sodium lauryl sulfate, because that's going to cause tissue sloughing. With less saliva flow, obviously the mouth is in a tedious balance and tedious condition. So you don't want to do anything that can disrupt that or agitate that. So again, you want to have relief for the dry mouth, approach the caries issue, raise up the saliva, and get some kind of paste or some kind of gel that will help increase that saliva flow, protect the teeth, and protect the gums as well. Some interesting things here I found that over time the polypharmacy of patients is really growing. To put dry mouth into perspective and how it affects caries, right now 78 million Americans have hypertension. And this is actually a 2006 study, I think, that I pulled out here. But what's fascinating about this is, even though this is, say 9, 8 years old, you go after this and you look at certain medications and how they're bundled, and we all know that these, lead to reduced salivary flow, but do our patients really understand that? It might take them 1 or 2 appointments to realize, hey, my saliva is really a lot less here, and I have dry mouth, I have a hard time speaking, I have a hard time swallowing. So again, it behooves you to take a good medical background and make the right kind of recommendations for them. Another interesting sidebar is the average patient right now, 75 or older, is taking around 11 medications. So again, these work in tandem often to really create the xerostomia and the dry mouth issues. So get on top of that, have the conversation with your patient, and grow their confidence in what you can help recommend to make it better. Another prevalent condition in developed countries, because this is what we see here with our diets, is dental erosion. And it's caused by sustained direct contact between tooth surfaces and acidic substances. Extrinsic and intrinsic acids cause dental erosion. The clearance of the acids from the oral cavity, essentially using more saliva to a large extent, is dependent on that. It's the saliva flow rate you're going to look at, because saliva is the buffering capacity that we rely on here to balance that again. Once again, if you select the right kind of toothpaste, you're going to provide a longer oral health for that patient, and you're going to reduce their sensitivity. And these patients really do have sensitivity. They can come in and, we have different patients now with GERD is a real prominent issue that we see. Different GI upsets, different medications. There's a lot of presentations that are out there right now. We've got to be really cautious of this. Again, what we're recommending and making sure that they're using proper things that don't stir up their gingivitis and their sensitivity as well. me go a little bit into moderate decalcification, because this is something that we see very often, probably more often than I really like to admit that we see this, but every office needs a strategy for white spots, or as we call them in our practice, we call them white scars. Not only is this patient's enamel solubility at play, but their diet needs reviewing, as well as their home care regimen. So it's a big picture here. This patient's in her mid-20s. If we want to have any kind of game plan for her longevity-wise, we've got to tackle this, get on top of this. We've got to question and find out everything talked about. What toothpaste, what toothbrush, what's her diet, how much is she brushing, when is she brushing, all of these kind of things. It's better to partner with certain products to know that you're going to, again, use calcium in a right availability and the amount of fluoride to go in and really tackle these areas and bring back that balance that we talked about earlier. So very, very important. It's interesting, too, to know that a lot of times within 6 minutes after they've brushed, patients brush with certain different toothpaste, they can actually bring that balance back up to that 7.4, 7.2 level. So it's critical to understand if you can minimize how much you're asking them to do, but maximize their benefit, it's really great. In our practice, we like to try to eliminate the need for remineralization paste, prescription toothpaste, and take-home rinses. We find often that they get confused about how to do these, even though we write down instructions. They're confused. They interrupt the effectiveness of where they need to be in that window of working time. And so if I can make this streamlined for them, give them one product, which we found to be very, very effective in enamel-on, gel and toothpaste, we're getting a huge benefit, and we're getting better compliance because patients know it works, they see the success, and they feel the success. So it's a win-win for everybody. Ortho patients, another challenge here to oral hygiene. They've got to properly angulate their bristles, insert floss threaders, you name it. Work to completely remove the biofilm and plaque and debris around these brackets. It's a tough job. There's a lot of obstacles with orthodontic care. We found that in our practice, about 3 months prior to a patient we know that's going to be getting orthodontic care treatment, we like to introduce at that point in time, 3 months ahead of time, a consistent Dentrifice regimen. So we make sure that we're getting them to be compliant with something. And our choice at this time right now is enamel-on, and we found very good success. Kids like the flavors, adults like the flavors, and teens like the flavors, and that's really, really critical. Again, you're getting a win-win there. We're having them brush in the morning with toothpaste and then use the gel, especially at nighttime, toothpaste and then the gel at nighttime. Another area that sometimes gets overlooked is, again, another orthodontic layer, but you have a lot of clear aligners on the market today. And two things that matter there: you don't want to have any of the patients using any kind of very abrasive whitening toothpaste, because once they put the plastic aligner over their teeth, it's covered now, and no exchange of saliva can help calcium work in those areas. So be one cognizant of that. So you need to have, again, a strengthened enamel and a strong enamel with the right uptake and the minerals in there to make sure it's protected properly before you cover those teeth with plastic. Another thing is we have more and more patients that have had a lot of restorative care. They are living longer. They need to keep their teeth and their oral conditions in pristine shape. So again, proper toothpaste choice, very critical, very, very important. One of the biggest challenges that I think we find and we have is creating and maintaining proper oral hygiene routines for kids. And I spoke last week at some of the schools here in Columbia, and it was great. And it's fun to look at these kindergartners and think about what they're going to face in their life. But some of the things we, really mentioned, brush twice a day, 2 minutes at a time, very important. But these, again, are kids under the age of 8. And I firmly believe that anybody under the age of 8 absolutely needs supervision. That's first and foremost. Kids will dispense too much, and then they'll ingest it. So again, we're back to supervision and delivery. They need hands-on assistance as well. Until after age 8, they're not going to know how to brush and have the dexterity and the means in which to do that too. So they need assistance in brushing and flossing. Don't ever assume that parents or new parents even know how to do this as well. So you've got to not only educate the kids, but you need to educate parents. And this is really creating an educational tandem with the guidance that shows your office really does care. We also need to consider the developing teeth. their mixed dentition and future orthodontics. So you're kind of laying out a path and setting the stage for their lifetime of good oral health. Really critical. I can't emphasize enough the education that really needs to go into kids and their parents as well. Besides a properly sized toothbrush kids require specific amounts to be dispensed. And current literature supports the guidelines here for dispensing toothpaste. So you can see here, kids under the age of 2 require a smear portion on their brush and a very small brush. Kids from ages 2 to 6 can have a pea-sized amount dispensed on their brush. You might be recommended by a pediatrician that kids under fluoride might need a fluoride toothpaste if they are in a high caries risk. Again, work with your local pediatricians to figure out what you need to do. But I want to be confident that if I do work with a local pediatrician, they're going to know that I have a product that I can relay to them that's going to be very safe and very confident with a dispensing dose, very small, and it's versatile enough that the whole entire family can use it. So really, again, critical to know that you've got something in your suggestion box that works well for these types of patients as well as all of your patients. It's extremely versatile. If you sit there and look at a pea-sized amount, you're looking about 0.25 grams, and you're looking at the treatment gel, you're going to get about a 0.24 fluoride versus a 1.25 milligram fluoride in an identical volume of toothpaste in a typical 5,000 parts per million counterpart of dispensed toothpaste out of a traditional product we've used in the past. It's interesting to know that in testing, even though you have a 2.5 times greater uptake in fluoride with enamel on the incipient lesions, you're having a lesser dose of fluoride. So again, lesser amount of fluoride, less can be better in this case, but you can get a greater benefit. And if I can get a stronger enamel for that child, that's so much greater and so much better too. What's interesting to know too, besides the gel, it has a 30 times greater uptake. So these lesions, any kind of incipient lesion is really going to get strengthened and really get tackled effectively with a product, again, that's extremely versatile, but more importantly, it's really safe. So you look at this cleaning equation here, and proper daily home care may be seeming easy for most of us because we're in that world, but given our patients' crazy schedules and distractions, it's easy for them to stray away from their instructions. I mentioned that patient earlier today that is going through chemotherapy and has xerostomia. She was very confused how to use different products that we had recommended for her. And again, we wrote it down and went through it. We went through it once, we went through it actually 3 times. But compliance is tied to what they know is an action or a need. So you've got to create that need for them and make sure they understand that. It's a whole equation, and it gets very complicated quickly, and when you introduce more and more products, it does get more and more complicated. So they need to understand that we can really shrink that down and be a lot more specific and really streamline products to really say, hey, if one product can now work for all of this, it's a better win-win. And I think less confusion is better for our patients. So it's really important to know what products you're putting out there, but also to know that you don't have to use as many to get the most effectiveness here. And that's really what I want to bring forward today, because it's important to know that a lot of times we recommend things. A lot of studies are out there showing, say, 30 to 60% of health information that's provided to the patient is forgotten within an hour. So you've got to make sure you follow through. And how do you do that? Maybe it's a text message, maybe it's an email, maybe it's a phone call. Usually by the time they got home, in a lot of instances, they've forgotten what you've recommended. So it's important. Go over it, write it down, but follow up to it. It's very, very critical. Our professional advice and recommendations are really successful when we have patients who are really prepared to make a change too. So they need to be motivated, and it's incredibly important to have that kind of relationship with them to show that we care, we recommend things that we know will be successful for them. And I think they're very appreciative of that as well. In our practice, we try to narrow our approach like I talked about. Meaning if we can eliminate some of these needs for some of the remineralization pastes and prescription strength toothpaste and other rinses, I think we improve our chances for compliance. And I think the patients really find that welcoming as well too. And we're hearing very positive feedback from them for those reasons too. So really critical. One of the things that we do in our office, we do in-office dispensing. And for years, it's interesting, the hair care industry as well as salons and veterinarian professionals have capitalized on this, and it's really starting to become more mainstream in dental practices, and I think it's great because it makes your practice look like you're in the know. You look like a full-service approach to dental care, and I think that's really important too. We found that clinically, patients are very receptive to the dental products that you do recommend. They look to you as a person who is an oral health care provider. You have the knowledge, guidance, and recommendation, and you can help cut through that lot of that noise out there and the confusion, and provide the proper messaging with the education that can help them and lead them in the right direction. So I feel that this is something that really helps build and confidence. It helps find the right value that you're approaching for your patients, and it brings in their loyalty as well too. So it's a great approach, and I think you see good value from this as well too. So if you can bundle certain things together with treatments, we do specifically with ortho and perio in our practice. We found that's been very successful. And we're very committed to sending home the best for our patients. And we find that this, again, creates more of a consistent messaging. Again, it's all top to bottom approach and how we care for our patients and how we want to feel that they know we do care for them immensely in providing the right types of suggestions and recommendations. So we're there for their success. We're there for their dental longevity, and I think they know that and they appreciate that. Looking at specific dental conditions that a toothpaste has to target can be a little bit overwhelming. And I've thrown a lot of information out here tonight, or today. It's a lot to absorb, a lot to put together, but hopefully as you start to look at the data, you can kind of find there is clinical winners out there, or a winner, and you can get a better understanding of what really works, what's safe, what's practical, what's versatile. And rather than trying to add more confusion to the hygiene routine, hopefully you can realize and make sure that you know the chemistries that are present and get a better understanding of a tooth cleaning regimen that's safe and simple and really versatile. And I think that's a very important approach in how we go every day for our patients and what we do for them. First and foremost, it becomes imperative as oral health care providers we continually educate ourselves and stay current with dental products and how they can benefit our patients. If we dive into the science, turn off the marketing, I think we can really settle at a place that we know in turn we can take the knowledge and we can educate not only ourselves but our patients and customize their approach and their home care and really promote more compliance. And I think this really does come down to compliance. Give them the tool that can work for them, and they can work it and make it work. This exchange opens the door then basically for improving your patient, and I think you become more trusted as your role in the practice, and you're the dental health advisor essentially. And I really like this phrase, the only real voyage of discovery consists not in seeking new landscapes, but having new eyes. And I think it's how we look at things and how we make that approach and how we improve and know that we can bring new, exciting products that are on the market that are tried and true, that are clinically driven, that help push out a good message and a good win-win success for our patients. So that's exciting. It's neat to see. We're in a great age right now of dentistry, great time to be in our profession. And we see and we make so much difference and so much change. It's a very, very, very exciting time.